I'd like to thank the organizers for the opportunity to present our experience of consolidating person-level health data for both operational and research purposes, and to greet all the attendees. My name is Andrew Bull. I'm a public health medicine specialist with the Western Cape Government Department of Health, and I'm responsible for our Provincial Health Data Centre, where we bring together the all person-level health data that we are able to. To describe briefly where I work, the Western Cape is a province of about 7 million in a country of 60 million, and we really do exemplify what people often refer to as the quadruple burden of disease, including quite high neonatal, perinatal mortality, infectious diseases, causes of mortality, violence and injury, and non-communicable diseases, which are of increasing importance over time. And in terms of SARS-CoV-2, it's not fully appreciated that South Africa has actually had a very pervasive epidemic. It's underreported in the sense that our mortality reporting, our official reporting of COVID deaths is a small fraction of the excess deaths that are reported from vital registration. But if we take the excess deaths as meaningful, then the South African experience is amongst the most severely affected in the world. The blue line at the bottom here shows the Western Cape daily deaths, and you can see that this is per million. And you can see that although we had a very flattened trajectory, even still at our peak, our mortality was amongst the highest in the world at the time that we had our peak. The digital health context is that we don't have electronic medical records, but we do have fairly uniform patient registration systems and share unique health identifiers. So we are able to bring together quite a lot of different administrative data systems in one place. So focusing on supporting operational health services, we're not trying to do anything too complicated on the operational side, just identify those patients who need care and to leverage as much of the relevant information as we can to support that care. But we have to do quite a lot of footwork to triangulate these data from different non-EMR sources and turn them into valuable data. And what we're going to talk about today quite a bit is also using the same data to support epidemiological analyses and the research enterprise. Very briefly, and I'm going to go through this very quickly. We curate the data in terms of person, time, place, and clinical coding system. We beneficiate the data by turning it into things that have meaning in terms of clinical encounters, clinical health condition or health conditions, and then care episodes. Essentially, we take data from all these different sources and we combine it into summative evidences supporting a health condition, and then we probabilistically come up with the probability of somebody having a health condition, and then we try and attach all the attribute data that we think has relevance to that health condition and turn it and create essentially a virtual cohort, which we call a cascade. And those cascades, and they're quite extensively described in this article in the journal Population Data Science, become the engine room of alerting, of management reporting, of being a portal to consolidating the data for an individual for clinical care purposes, or almost like an EHR that is derived from multiple sources. And there's an example of a graphical interface for the single patient viewer as a clinical reporting system. This is an example of an immunization cascade, which is derived almost entirely from inferred data, given that we don't have full data on all immunizations given. So we have to make inferences based on data of attendance, immunization schedule, etc. And moving on to the research side of the platform. So the prescripts that govern us are very standard, that we have patient protection imperatives. There's legislation, health legislation, protection of personal information legislation, access information legislation, We apply data controls, both procedural and structural, and we try to ensure sustainability of our environment from a data protection perspective. We often, when we engage stakeholders, go through a checklist like this. I won't spend time on it. You can pause and look at it if you want to. But the last question is quite instructive, which is, if I were a study participant, would I be happy with the way my personal health data are being used? And it drives us to be quite stringent in ways that are much more stringent than happened before the data center existed. So some of the things that we do in the data environment around patient protection are the strict differentiation of named and clinical attribute data, so that most analysts wouldn't have access to the patient identifiers. Where we do have to make patient identifiers available to people who are developing reports, we mask the identifiers using the kind of masking capabilities of modern enterprise databases. For people who are gaining operational access, we do our best to limit that access based on an individual carer's mandate and remit in terms of patient care. We've centralized all requests for health data to one portal of access so that we can apply good governance to all requests, which is a massive shift from what took place previously. And so all requests are vetted in terms of the proposals, if they're research requests, and that the data being requested are truly needed for the purpose of the request. And we steer the requesters to the safest possible options, even if they've got permission for more expansive access. And named data are essentially only available where there's individual consent, except for very, very rare circumstances. Our experience of doing this has been quite interesting. Initially, there was some resentment about centralization. People felt that they were being forced into a portal of access that they had less control over, and that there might be more delays in getting their data. But I think over time, people have really appreciated that they can get much more complete data, many data sets that they couldn't gain access to previously. All the linking is done up front. They realize that they're operating with much less risk. Many projects that weren't previously feasible are now feasible because of the ability to provide the identified data that's been linked, whereas for patient protection reasons, those data would not have been available previously. Overall data governance, we think, has improved. So there were many concerns when we set up the environment where people felt that it would be a risk to patients to have all their data in one place. But quite the contrary, we found that by having all access requests through one portal, we can ensure a level of governance that just didn't exist previously. So we actually think it's improved governance quite substantially. And overall, we think there's more data provision and research facilitation than existed previously. One of the things is with our stakeholders is trust, and to maintain trust, we've really had to demonstrate, and it's been our intention to with the data center from the start. It's why we've put the energy in to develop it, but we've really had to demonstrate the importance of meeting the operational needs of the services first and foremost, even though sometimes researchers can be very have a lot of agency in advocating for us to prioritize their research requests, because we haven't wanted any of our stakeholders to think that the data center was essentially a way of extracting data to support the research enterprise. In terms of areas that we haven't done a lot of, but we feel that we can support the research enterprise further, one is community-based research. So there's more and more work being done with frontline health workers doing surveillance directly with households and individuals. And once again, we don't believe that these should be separate parallel systems, but that there should be a single integrated system. We don't want separate healthcare workers going to households and then researchers going to the same households asking the same health questions. For experimental data coming from high throughput omic type platforms or clinical studies, maintaining long-term phenotypic outcomes for those studies is very difficult. Case holding and long-term follow-up is very difficult in our context, but with a consolidated environment and with the right consent and permissions, we believe that we can continually update and de-identify those data sets for researchers. We can also provide a way of finding patients that to facilitate research where one has to look over quite a large platform to identify patients for a particular research question. We would never allow researchers to approach patients directly, but we could certainly give clinicians opportunity to offer participation to their patients. And even for routine clinical studies, we find that we can often help researchers get much more complete follow-up than they themselves can achieve if they just try and follow up the patients directly from the clinical site. To put a COVID lens on this shared operational research environment, having the shared environment and the patterns in place for onboarding data from multiple sources definitely helped us be responsive to the COVID challenge in terms of case identification, outbreak response, tracking our operational response in terms of contact tracing. And the data center became a very central part of the outbreak response operationally. But also we were, from a research perspective, very quickly able to do an epidemiological study on the impact of HIV on advanced COVID outcomes. Looking at COVID mortality, we were able to demonstrate, and this is on a log scale, that HIV doubled the risk of mortality in patients with COVID from a community perspective. So even though we weren't enumerating all cases, we could look across the entire public sector cohort and work out who was at most risk of dying from COVID. And this is something we were able to do in the first 4 weeks of starting to see COVID-associated mortality, and this helped us to anticipate the extent of this risk very early on. This slide was prepared for a completely different purpose as to the contributions of the Provincial Health Data Centre, and you'll see that the last two the first three are all operational, but the last two objectives really are around supporting the research and analytic environment, and part of it is also about sharing data with modelers and with the public. So we had a public-facing dashboard from very early on that had much more comprehensive data than anyone else in the country was able to share. And so another lens is perhaps beyond research is also on transparency. So in summary, we definitely believe it's feasible to have a single environment to service both operations and research. That our experience has been, rather than increasing risks around data governance, we've massively improved data governance. That new research opportunities have emerged as a result of doing this in one environment rather than separately, and that perhaps I haven't spoken about enough, this joint operational and research mandate actually has enabled us to staff and attract staff into the environment that we might have otherwise struggled to do. So we found that they very virtuously feed off each other and create a much stronger joint environment. With that, I thank you, and I just want to acknowledge my many wonderful colleagues who have worked tirelessly to establish the environment and continue to support both operations and research requests. Thank you very much.